Health, August 2022. We're now, don't welcome yet. Reset. I'll welcome you again. It's like watching TV, watching the reruns. Okay, welcome to the final section of Labor and Health, August 2022. This is the final sequel. It doesn't have a name yet. If you think of a name, please feel free to name it. We are going to start off this afternoon talking about mental health workforce and interstate compacts. And there's not very many people here, so whoever needs to come up. We've got 4 chairs. Please come forward. Oh, yep, and we have an announcement while you're coming up.
Right.
Chairman Wilson.
So meanwhile, to the committee, don't forget to fill out your reimbursement form so you get paid the vast sum for which you're being paid to do the people's work. And the second thing, thank you, Chairman Baldwin, is I just want to make an announcement. Tomorrow there is a conference happening in Cheyenne, How to Be a Force for Life in a Culture of Suicide. It's for all sorts of folks, teachers, counselors, clergy, legislators, nurses, lawyers, chaplains, first responders, and so on. It's taking place at Cheyenne Hills Church. The cost has been covered. It starts at 8:30, and they have managed to obtain 3 hours of continuing education credit for professional folks. So I have a little bit more of the flyer on my phone if anyone is interested. But again, I realize that not everyone will be in Cheyenne tomorrow morning at 8:30. But if you are and would like to attend, the speaker is Dr. Matthew Sleeth, who has written a book called Hope Always. He was an ER physician and now does teaching and all about suicide prevention. So thank you, Mr. Speaker, or Mr.
And while we're on the subject, I'll throw a couple announcements out there. 22nd, 23rd, and 24th for first responders here in Casper. There's a conference, mental health. I call it the summit, but it's not a summit. It's a conference, but that's for all first responders, firefighters, EMTs, policemen. Should be a very good conference. It's also certified for, I forgot what it's called now, but through the academy, through the police academy certification. And finally, I'm sure Jen would like to announce this at some point, but since she set a date officially yesterday, I saw it on October 11th. Is that correct? October 11th, the Mental Health Summit here in Casper. And all the cool people will be here. So please put that on your calendars. And is everybody in this room? I'm sure we got the right people in here. Wyoming's still #1 in suicide. We really would like to get off the top. We really would like to move down that list a long ways. So I think all these conferences we're talking about, they all go a long ways towards that goal, and we need to really work on that. That's all the free paid announcements. Now let's move ahead. Ms. Semino.
Mr. Chairman.
Go ahead, ma'am.
Mr. Chairman,
Oh, go ahead.
were there any staff directives for the last topic?
I don't believe so.
Okay.
Not yet. Well, we'll talk about that at the end, at the very tail end.
Okay, thank you.
Okay, thank you. Okay, Ms. Semino, go ahead, ma'am.
Mr. Chairman, members of the committee, Lindsay Semino with the Wyoming Counseling Association. I'm here to present you with the Counseling Interstate Compact. We ran this as a bill this last session. It was Senate File 54. It did pass Senate Labor pretty successfully and then ran out of time with Committee of the Whole. So we are asking that the Labor Committee presents it as a committee bill this upcoming general session. What the Counseling Compact will allow is an interstate compact, and that will give us the constitutional, it will constitutionally authorize legal binding contract between states to allow those in good standing with master level counseling licensure to practice in the states that have joined the compact. As of right now, we have 15 states that have enacted the compact, meaning that earlier this spring, the compact is active. It's early enough in the process that with Wyoming joining next year, we will still have the opportunity to be involved in rules and be involved within the commission. Neighboring states that have also passed the counseling compact is Nebraska, Colorado, and Utah. Some misconceptions about the counseling compact is that it may decrease public safety. The reality is our counseling compact increases public safety. The compact has a disciplinary commission board so that when a counselor has a disciplinary action in a compact state, the compact state reports them to the board. The other misconception is that Wyoming then loses control over their counselors. This is also not true. The compact has what is called a home state, the state that the counselors reside in. Our counselors must have a home state licensure. They must maintain that licensure in order to be part of the compact and still abide by our rules and regulations. So Wyoming keeps its control while also allowing its practitioners to practice across state lines more easily, more efficiently. And with that, it's very similar to other compacts. For example, the occupational therapy compact, I know that passed through the House this last session. I think the other thing to note is that it is a privilege to practice compact. This means that we as professionals are paying our licensure board for the privilege to practice in other states. This means that a provider can choose to participate and pay that extra fee, or they can choose not to. So it's not necessarily something that will impact all counselors. I will tell you that that fee, though we don't know what it is yet, will be less than what most practitioners pay when they do reciprocity licensures in multiple states. So it's going to be more cost beneficial to those providers. With that, I stand for questions and would love to assist in any way I can.
Questions, committee? Go ahead, Representative Conley.
Thank you. And as you know, Ms. Semino, we've got 2 of these interstate compacts before us. And
Yes,
so my
ma'am.
first question is, are licensed psychologists per se licensed counselors, or are they completely different?
Ms. Semino.
Mr. Chairman, Representative Connolly, every profession needs to have its own interstate compact, and we are, sadly, it would be way simpler, different professions. Most clinical psychologists have a doctorate, and I will allow my colleague, Dr. Hollis Hackman, to speak more on that. Counselors are master level trained. We have master level training in clinical counseling. I hope that makes sense.
Real
Follow up.
clear. So the answer is no.
Correct.
Psychologists are not licensed professional counselors, and they couldn't be given their training and background.
Correct.
So, Mr. Chairman, if I
Go
may,
ahead.
so then I was just concerned because, and again, I didn't read this with a fine tooth comb, because in interstate compact, you don't want it to be too different from one state to another, and right? However, there's a definition of adverse action in each one of these compacts, and the definition is different. And that concerned me a little bit. But I think from what you're telling me is that because these professions are so different, they're as different as saying a physician and a therapist, or a dentist and a counselor, right? And so it would be okay that we have different definitions for an adverse action, because you would never fall under both of these, given your background.
Mr. Chairman, Representative Connolly, yes, that is absolutely true. These compacts are formed with the Council of State Governments and the professional stakeholders. And so it's common that those professional stakeholders and those professional associations come up with different adverse actions that fit those different professions.
Great, thank you, Mr. Chair.
And you hit on an important feature of the compacts, and that is language has to be the same in each of these compacts. We can't take it and amend and amend and amend, because that would make it not work. They have to be the same from state to state. And those on the committee that have worked on these compacts, we've worked on a lot of them. How many we got now, Mr. Chairman? We've done a bunch, and they've made a big difference. I think I take physicians as an example. We're getting physicians in easier because of licensing issues. It's a big deal. So with that, further questions, committee? No further questions. Who's next? Go ahead, introduce yourself and go ahead and tell.
Thank you, Senator Baldwin. Kelly Heenan. I am the licensing board chair for the Mental Health Professional Licensing Board. So I represent on that board licensed addictions therapists, licensed clinical counselors, licensed marriage and family therapists, and licensed professional counselors. So I can speak today to the board's position related to the counseling compact, but the psychologist compact would have a different board overseeing that. And I'm going to keep.
That was very good. Go ahead, proceed.
Thank you, Chairman Baldwin. As a board chair and board member, our board currently supports this compact. We can see a lot of utility, particularly I'll use my field as a marriage and family therapist. If I happen to live on a bordering community and I'm working with a child, maybe dad lives in Montana, mom lives in Wyoming, or Cheyenne, dad lives in Wyoming, mom lives in Colorado, it does open up ability to treat the entire family in an easier manner or fashion. Or we have a lot of transient families in Wyoming who may go from different communities based on their job, like North Dakota, Texas. So this could potentially open up an easier avenue for providing treatment to not only Wyoming families, but also if you need specialty consults, you can reach out for those more easily across state lines when you have a compact. As Ms. Semino said, we're not sure what the fee for the board it would be to participate in the compact. So that is one unknown factor, but it's not a concerning factor. We would not support the compact.
Questions? Go ahead, Representative Stivar.
Thank you, Mr. Chairman. You said there was 15 states that signed this compact already? What are the 15 states?
Go ahead, Ms. Semino.
Mr. Chairman, Representative Stivar, if you'll allow me to name all the 7 dwarfs real quick. Our neighboring states are Utah, Colorado, and Nebraska. As far as the other states, we have Maine, New Hampshire, Ohio, West Virginia, Maryland, Delaware, Kentucky, Tennessee, North Carolina, Georgia, Alabama, Mississippi, Louisiana, and Florida. And then there is 4 states with pending legislation, which is New York, Minnesota, Iowa, and Missouri.
Follow up? Nope. Go ahead with follow up.
Thank you, no follow-up.
Okay, no follow up. Further questions, committee? Okay, thank you very much.
Mr. Chairman, very quickly, we are working off of the language from the bill from this past session with the effective date being July 1st, 2022. I would ask that the committee move the effective date to be when the bill is signed, as then it will allow Wyoming to enter the commission and the rules process the moment that it is passed and approved by the governor.
Very good. So can you keep that in mind as we go through the bill, when we work the bill? That's something we know we'll need to fix. Okay. Further testimony, gentlemen. Mr. Hollis.
Good afternoon, Mr. Chairman, members of the committee. Hollis Hackman. I'm the legislative chair for the Wyoming Psychological Association. I have with me Dr. Don Benson, who's the president of our association for the state, and we're here to talk about the Psychology Interjurisdictional Compact. And this may be familiar to some of you because we had this bill 2 sessions ago in a budget session, and it actually passed the Senate side. But for those of you in the House, you never got to see this bill because we ran out of time. It was a budget session. But there was also some pushback from some of our membership. Not everybody in our organization is supportive of this effort to sign on to an interjurisdictional compact. And that's still the case, although the majority of our folks that responded to a survey about a year and 3-4 months ago were in favor. So we want to do another survey. We want to continue to get information out to our membership about this compact, and hope that I can have a definitive answer for you in terms of, well, where does our association lie with this? Again, we have a majority of people in support, but we have people that have concerns. Some of those folks don't have the same level of concern that they used to because time has ticked on with this interjurisdictional compact, which goes by the moniker PsyPact. And so I have an update for you in regard to what's happening nationally with PsyPact, and I can give you more information about our survey that we did in May of 21. But that's how I'm planning on proceeding. So if that's okay, let me just mention that at present we have 34 states now that have signed on to this compact for psychologists. I think 2 years ago, it was in the neighborhood of kind of where the LPCs are right now with a dozen or 15 or so. But nationally for psychology, we're at 34 states. And Representative Stivar, I did call up a map on my little iPhone here that I can show you all the states, but there's 34 of them, so. We're surrounded by SIPAC states, short of Montana and South Dakota, but Idaho, Utah, Colorado, Nebraska. Anyway, this compact has been around a little bit longer and it's got a little more in terms of momentum, I think. And the commission has been established and the rules and regs have been established. Actually, they're open for public comment right now. You can, if you just do a search of SIPAC on your browser, it'll pop up. You can go to their website, see their map, and you can see what the latest is with the rules and regs and that sort of thing. So anyway.
I believe Representative Stivar has a question, and I would request maybe LSO can find that for us and send that to each of us so we can put that on the big screen in front of us so Mr. Hackman doesn't have to be Vanna White. Go ahead, Representative Stivar.
Just a comment, Mr. Chairman. That's what I was looking for with the states around us, because I don't, because somebody practicing here from Florida is probably a moot point, but it's the states around us that really, and so you answered that question, so thank you.
And I would add to that the other group we haven't heard from is the military, which makes a huge difference in those other states that don't touch us, the military folks that move a lot and their spouses are perhaps counselors or whatever the case be, whichever we're talking about. And this allows for easier employment. It makes it easier for them. So I'm sure we will hear from them. But go ahead and proceed.
Yes, Mr. Chairman, we typically do hear from Department of Defense who are very supportive of these compacts because people that are married, as the chairman's pointing out, you get moved around when you're on active duty, and every time you move, you got to get a license now to practice in that state, depending on, if you're in a private practice or something like that. And so for spouses of military folks and such, these compacts are very helpful because they really are a reduction in regulatory barriers is what they are. And it increases access to care for folks, generally speaking. So anyway, in regard to updates now, 34 states have passed SIPAC and have joined this compact, and they just have analyzed data from the first full year of when providers were eligible to practice under this compact, this last July. So the first full year, when this was in effect, is from a year ago, July, to our current July. And just some information about that. Those folks then have to renew because there's an annual renewal fee. And the SIPAC Commission has a questionnaire that people fill out and indicate what they've been doing with their credential. And so here's some of that information. So of all those folks, there's 3,400 authorized psychologists that were due for renewal. And of those folks that renewed, 67% of those folks actually practiced with that credential under SIPAC. And of the 67% that said they practiced under SIPAC, 26% of those provided services in rural areas. So 26% of those folks that have this credential are practicing in a rural area somewhere within those compact states. There are currently 34 states on board. 31 of those are presently effective. It's something I neglected to mention. Also, of those 67% of people that are renewing, 45% of those folks saw 11 or more patients via telemeans. So people are getting this credential, they're practicing with it, they're seeing multiple patients, and 27% of that patient population is in a rural setting. So, and that's one of the benefits of telepsych sorts of provisions, that you can reach out to rural areas where people don't necessarily live.
Chairman Wilson.
Thank you, Mr. Chairman. So my question really is more for the benefit of the members of the committee, whoever shall remain next year going forward, because this compact is a little bit different, and we're looking at the one from 2020, but it's a little different from other compacts in that, so I'm looking at page 3, for example. This compact is intended to regulate the temporary in-person, face-to-face practice by psychologists across state boundaries for 30 days. And then the paragraph above it, day-to-day practice of telepsychology. So the first question will be, just to be clear, so the person can practice telepsychology at any time and 30 days face-to-face, I think is what I understand, which is, I mean, different than other compacts who typically don't have that bifurcation. And then the other thing to just bring out on page 20, it seems to me that 2 years ago, there was some concern expressed about the jurisdiction of the Wyoming board, and that the compact might be a little different than others. But I see on the bottom of page 20, it says, a psychologist practicing into the receiving state, which would be Wyoming, will be subject to the receiving state's scope of practice. And then the receiving state can take any other necessary actions to protect health and safety. And I didn't find, is there a difference in the subject to the receiving state scope of practice on telepsychology versus face-to-face? Because there was that bifurcation in how often they were authorized to practice. So do you grasp my two questions?
Mr. Chairman, Madam Chairman, let me try to answer both those questions. So yes, there are two components to this interjurisdictional compact. One has to do with telepsychology, which is all telehealth stuff. And the other has to do with the ability to get a temporary license. Now, our current statute already provides for a temporary license. You can get a temporary license for, I think, 30 days. The difference here is with this compact, if we're part of this 34-state compact, then your temporary license is good in any of those other 34 states, as opposed to you have to petition every one of them individually to get a temporary license. So there's that part. And now the second part had to do with jurisdiction. And if I remember your question correctly, yes, if you're practicing into Wyoming from another compact state, you have to practice under our scope of practice. And since our scope of practice covers already temporary licenses, that you're going to have to follow those rules. And if you violate our rules and we have a complaint, our board directly notifies the home state from where that psychologist is from. And the home state is primarily responsible for resolving whatever that concern is. But Wyoming certainly reserves the right under this compact to, if we want to pull somebody's license because they're a bad actor, we can start that process, but then the home state has to take care of the loose ends of it. So I don't know if I answered your question.
No, that's fine. I just wanted to, and because what I'm looking at specifically about subject to receiving states, that sentence says authority to practice telepsychology, and I just wasn't sure if we did something different for the face-to-face people. I mean, it did seem to me that there was a little bit different way in which the board's authority was a little different in this compact than in other compacts we had. I think it was just the need to, I mean, we could certainly stop someone from practicing in our state, I would think, regardless of what their home state did. But I'm just, thinking back on the 2 year ago discussion. But it seems to me that we've we've got everything pinned down. Whether it was different than it was before or not, or just the understanding is better now, I don't know, but.
Mr. Chairman, Madam Chairman, this is the same language from 2 years ago. I think somebody mentioned earlier, it might have been Mr. Chairman, that the language in these compacts are uniform and all the states have to sign on to them, and they're written such so they've got some flexibility to accommodate all the different states, but the language is pretty steady. And there haven't been any, I asked SIPAC before this meeting about, are there updates? And there haven't been any changes to the Model Act, which you have before you. And in my reading of it, all 78 pages last night, just to kind of refresh my memory, generally, when there's a section that talks about the telepsychology piece, there's a mirror section that talks about the temporary practice authority piece, and the language is nearly identical from what I can tell. But I do think that if you have a more specific question, I think Joanne Reed, who represents our board for the state, is in the background somewhere standing by at Zoom if we need her to ask a specific question, because she's also familiar with this, as we had to have a lot of this worked out a couple years ago.
Very good. Anything further?
Mr. Chairman, I was just going to mention something about our survey. We did because we had controversy about this 2 years ago, we did a survey a year ago last May. We mailed the survey out to all the license holders in the state, not just the members of our association. There's 350 or so license holders, but only 150 or so actually practice and live in the state. And we had about 60 folks that turned in their survey response. So this doesn't represent everybody's opinion, but of that group, 76% of those folks said they would like us to consider joining a compact, and when offered choices, because we were working on a regional compact at one point, and that was that effort was withdrawn when you all passed the Universal Licensing Act a session or two ago. But anyway, 76% of the survey responders said they were interested in a compact. And of those folks, of those 46 folks, 39 of them indicated that SIPAC was the compact that they would have interest in. So we do have a majority of folks that support this, but there are folks that still have concerns, and we're working to get them information from SIPAC, because again, the commission's established now, the rules and regs, as I mentioned, are open for public comment. And so a lot more is known about this compact than was 2 years ago. And so I think that's the information that I have to share, Mr. Chairman.
Very good. Questions from Mr. Hackman? Go ahead, Representative.
Mr. Chairman, hi. Just to clarify in my mind how this works. Okay, so you have the commission established, you have the regulations, so that will not insist that everyone needs to join? No?
Mr. Chairman, Representative Ottman, this is all voluntary on behalf of licensed psychologists in Wyoming. If they want to practice under this law, they have to provide credentials to the commission. That has to be verified. They have to pay a fee. I think it's $400 for the telepsychology piece. It's $100 or $200 for the temporary in-person practice fee, and then those have to be renewed annually. But this is all voluntary for our providers. If one of our providers wants to get what is called an electronic passport, which is the basic credential to do telepsychology, once they've obtained that credential, then they can practice telepsychology into all of the compact states, as many as they wish. But if we sign on to the compact, the reverse is also true. So if providers in those 34 other states want to practice into Wyoming with their proper credential, then they can do that. So in theory, this would increase access to care for residents in our state, because there are a lot of other licensed psychologists that would be available to provide the service. Now, having said that, I will just note that out of the 34 compact states presently, about 9% of the people that are eligible for this credential have actually applied for it. So people aren't flocking to do this, but if I had to hazard a guess, my guess would be that it's our younger providers that grew up with these things that I had no clue about when I was a young provider. So this is, and we may have somebody that'll chime in here via Zoom to talk about the current state of private practice for younger folks lacking some other word, people newer to the career. But anyway, I'm not sure if I answered your
Yeah,
question,
you did.
Representative Ott.
I have a follow-up.
Follow up, go ahead, Representative.
And so I was going to ask about the fees, and I heard that we don't know those yet, but if the other states have signed on, then there's an idea. And I was wondering if is that per each professional person? If I'm a psychologist, I would have to pay that $400 or $200 every year. Okay. And the last thing I was wondering is that if I was to want to utilize a psychologist, say from Idaho or somewhere, how do I, as a customer, see that this person, if it's telehealth, see that, oh my, they're from Montana or Idaho or wherever, and how do I know, because I'm not going in their office and looking at the wall and all that, how do I, as a consumer, verify that? Thank you.
Mr. Hackman.
Mr. Chairman, Representative Ottman, the fees are for individual providers that they have to pay to secure these credentials. So it's $400 annually actually it's $400 initially for the credential to practice telepsychology, and then it's a $100 annual renewal fee. And for the temporary in-person credential, it's $200 initially with an annual fee of $50. And so now, in regard to your question about how does the consumer find out about where the provider is from, I'm not sure I have a clear answer to that, but if people were going to contact our state association and ask about how to find a psychologist, we would have that information. We would be able to give information about folks in the state who may be able to address your specific need. And if we then help you find somebody in one of the compact states, if there isn't somebody in Wyoming, then we can get that information and we'll share that. And I'm glad you mentioned this, because it does bring up one of the benefits to the compact, and that is that there is going to be a way to verify who is credentialed and who is licensed. So there's a greater amount of consumer protection that's at hand here by joining this compact. It's something I also related, and I'm sorry if I'm rattling on too far here, but there's also going to be a database that's maintained on all these providers. And we all have to now provide fingerprints and other background sorts of information. That all gets loaded into a database so that if somebody winds up being a bad actor, and to date there have been no such creatures, but I'm afraid there's probably bad actors everywhere. And if that happens with somebody that's in a compact, it's all the other states are immediately alerted, and certainly the person's home state where they're going to have to take care of whatever it is. But the point I'm trying to make is there's a certain amount of increase in consumer protection by getting involved in a large compact of this nature.
Very good. I believe Senator Hutchins had her hand up here a minute ago. Senator Hutchins, did you still have a question?
Yes, Mr. Chairman, thank you so much. And Representative Ottman asked some good questions that helped. Dr. Hollis, just maybe top 3 concerns that people have that don't want to get involved in the compact. If you could rattle those off, I'd appreciate it.
Mr. Chairman, I will do my best to do that. The three concerns, the top three concerns, were initially that there would be a real influx of other providers, and how would we make sure that those folks are compliant? So I've tried to address that a little bit. The next concern had to do with how would our board handle quote unquote bad actors from other states? Would we be responsible for conducting all those investigations? If so, that was going to cost a lot of money. But I have tried to mention that the home state is the state that has to handle concerns about bad behavior. So if, again, somebody was practicing into Wyoming from Idaho, let's say, it would be the Idaho board that would have to address that concern. I would think that the third concern had to do, again, with costs and startup fees for joining the compact. And I verified this morning with SIPAC that there is no startup fee. There is a fee of $10 per credential holder in any given state, with a cap of $6,000, which is the maximum that any state board would have to pay. And lastly, I think there have been some concerns that maybe telehealth isn't as effective as in-person treatment, but we're not aware of any. I mean, for just general talk psychotherapy, we're not aware of any literature that indicates that telehealth or telepsychology is somehow not as effective. In fact, in my personal experience, I practiced exclusively with telehealth technology my last, on a contract, my last 8 years with the VA. And I was doing particular interventions with post-traumatic stress disorder. I was using a manualized therapy. And my results were as good as in-person results that existed in the literature. So it's equally effective. There are some things you simply can't do via telehealth. I mean, if I was going to do an intellectual assessment, a full-blown WACE or something like that, you can't really do that on camera. There's too many things that have to be manipulated and worked with. I mean, so there's limits to what you can do, but for straight-up talk therapy, it is as effective as in person in most cases.
Did you have a follow-up, Senator Hutchings?
Thank you so much. Hollis, thank you so much for that. Just thank you also for working with the VA and the patients there. The SIPAC, can you spell that for me? I want to make sure I have that right.
Mr. Chairman, Senator Hutchings,
Go ahead.
it's PSYPACT.
Gotcha. Thank you.
And Mr. Chairman, I do see on the screen, we do have a private provider from Jackson that may be able to also provide some comment
I
about.
see that, and she has the giant yellow hand on her screen. Ma'am, if you would like to introduce yourself and go ahead and speak to the committee.
Thank you, Mr. Chairman, and thank you to the members of the committee. My name is Dr. Sadie Cole. I am a clinical psychologist practicing in Jackson. I'm a colleague of Dr. Hackman's and a former president of the Wyoming Psychological Association. I apologize for signing on to the Zoom late. I've been quite busy, as many of us in private practice have been. I just wanted to provide my support for Dr. Hackman's comments regarding SIPACT. The interjurisdictional compact, in my opinion, is very important for access to care in rural areas. And a couple of years ago, when this came in front of the legislature, as Dr. Hackman pointed out, the wording has not changed substantially. However, what we have seen is that more states are joining the compact, similar to compacts between other professions, such as medicine, in which a doctor licensed in the state of New York can become licensed in Wyoming via paying a fee and providing their credentials. This, in my mind, is very similar. The standards for becoming licensed do not change, and the benefits to the members of, to the providers here, in addition to our clients, the people of the state of Wyoming, I think are they far outweigh the cost in terms of any potential problems. The cost of, prosecuting or investigating a bad actor, as Dr. Hackman pointed out, that has not happened yet and would not be, hopefully, borne entirely by our board. The other important thing to note is that there are very few licensed clinical psychologists in the state of Wyoming compared to other states. I'll note, for example, that my license number in Wyoming is 631. They're numbered, in terms of the order of number of people. In Massachusetts, where I'm also licensed because I retained my licensure after becoming licensed there and moving back here, I'm actually from Wyoming originally. My license number there is 10138. So there are, orders of magnitude more psychologists in larger states than we have here. I think the likelihood that we're going to be competing with people from those states is fairly low. What I think will happen, however, is supported by what happened during the pandemic, which is that individuals who need care and have an established relationship with a provider will be able to maintain that relationship in the event that they have to move somewhere else. Thousands of college students had to move during the pandemic because their schools suddenly closed. High school students had to go home. Boarding school students had to go home. And that disrupts access to care for many of our clients. I personally work a lot with teenagers and college-age students. Working with adolescents and young adults is a major part of my practice and has been for most of my career. And I will say that the disruptions for many people during the pandemic were significant. If you have an established relationship with a care provider, and Chairman, you might think about your own doctor in this situation. If you suddenly were not able to access your primary care provider because they weren't licensed in the state that you suddenly found yourself living in, that would disrupt your care. So especially in psychology, when we have established relationships based on a long background that patients often don't want to have to provide to a new person, it's very important that we're able to maintain continuity of care. And I find it really interesting that so many states have signed on to the compact. I think Wyoming has an opportunity here to be at the forefront of joining a very important piece of legislation and a very important compact that will help not only all of the people in Wyoming, but people that live in other states who have providers that are here. And again, I'm thinking specifically of college students in this particular case. Mr. Chairman, I think to your point of reducing the suicide rate in Wyoming, we have an unconscionably high suicide rate for our population. The fact that we are always number one or number two, or at least in the top three for suicide in the nation is very disheartening. And I think that by increasing access to care in rural areas of our neighboring states, Nebraska, Utah, Colorado, I believe that we can actually allow more people in the state of Wyoming to receive access receive care and hopefully reduce our very high rate of suicide, which is a very problematic and high cost mental health outcome. So I fully support Dr. Hackman's report to the committee, and I hope that you'll consider supporting this legislation for both providers in our state and for the people that we serve. And I'd be happy to answer any questions about my experience in private practice, especially the last couple of years. But I practice telepsychology regularly, both here throughout the state of Wyoming, given how big it is, and also back in Massachusetts. And I've done that for many years and would be happy to provide any insight that I can.
Thank you very much, Doctor. Questions for the Doctor Committee? Your question. Go ahead, Representative Stivar.
Thank you, Mr. Chairman. My question is for Dr. Hackman. Assessments and testing. How does, I know you mentioned it, but there's a lot of things that, that people need them. How is that going to work with this compact of, face-to-face sit down, do the waste test, that stuff.
Mr. Chairman, Representative Stivar, as I mentioned earlier, there are some things you just can't do via telehealth in terms of IQ assessments or neuropsych assessments, or a couple that just jumped to my mind pretty immediately. In terms of doing other standard personality inventories and that sort of thing, there are ways to get those things done remotely, but you have to, certain things have to be in place so that you know, for example, that the person that's completing the test is actually your patient and not a surrogate or something else. So there are standards for practicing telepsychology that have been on the books with the American Psychological Association for 10 years at least, and more likely it was of 2007 or 8 when those ethical principles were published. So there are certain things that have to be taken into consideration when, and I think Dr. Benson can maybe give you a real life example of that.
Dr. Benson, please introduce yourself if you would, Dr. Benson.
I'm Dr. Don Benson. I'm a licensed psychologist here in Casper, Wyoming, in private practice. So Representative Stivar, we have a licensed psychologist as part of our group practice who actually resides in Kansas now. She's still a licensed psychologist in Wyoming, and she does assessment and testing. And she will get the information on the personality test that will be sent to her. But when it comes to some of the achievement or the intelligence tests or some of the things that require manipulations, she will have a technician in our office who is qualified to do these, actually do that part of the assessment. And the psychologist who lives in Kansas, what she will do is she'll take all the data, the interview information, and she will, construct the report from that. So that's been happening for a couple of years now with her. And so, as Dr. Hackman says, there are ethical ways that can be done because you can't really do, as we said, an intelligence test over a video.
Thank you. Follow-up, Representative Stivar.
Thank you, Mr. Chairman. Because on the waivers, the states kind of changed that up, and there's only certain licensed psychologists in the state that can do them tests. Is that correct?
Mr. Chairman, Representative Stivar, I'm not real certain about that, but we can get the answer for you. But I don't have it off the top of my head because I don't work in that realm. So I'm sorry I don't have a specific answer, but we can get that for you.
Okay, further questions, committee? See no hands waving on the screen.
Mr. Chairman, I believe that we had somebody else from the University of Wyoming that was going to chime in if they're available now. I'm not sure that they sent me a text and said they were. So.
Yep, I see the head shake from the staff.
Yes, it'd be Dr. Kilwine.
Hi.
Doctor, welcome to Labor and Health. Introduce yourself and tell us everything you know, or at least most of it.
Okay, Mr. Chairman, committee, thank you. My name is Dr. Kilwine, and I'm a licensed clinical psychologist based in Laramie. I serve the University of Wyoming. I also run and operate a small private practice. And then I serve as the Council of Representatives on APA for the state of Wyoming. And so what that entails is twice a year, meet with other representatives from across the nation, other divisions, and we talk about these issues that we're talking about today. And so I'm bringing my perspective from those three areas, going to try not to repeat too much from our wonderful providers that have already spoken. So I'm going to answer some questions that came up. One area about the licensing fees, and I heard Hollis mention $400. I'm currently licensed in 3 states, and I'm about finished with California licensure. And if anyone knows anything about California, they're sort of the highest standard of licensure in the state. I pay $400 to be licensed in the state of California alone. And so when we're talking about this $400 fee to enter PsyPact, that's cost saving for our providers. So for me, being licensed in nearly 4 states, I'm paying $1,000 or more in my licensure fees. I'm having to get hundreds of hours of continuing education just to serve those states. And so there are vast benefits for our providers in this state who maybe want to serve folks in other states for a variety of reasons. So speaking to the university, our population specifically is we have college students from all across the nation, which is great, and it's great for our state. We have a lot of students coming from Colorado, so just across the border, who may be crossing that border once a week, certainly, once a month. They're going back for breaks, for holidays, and things like that. So our providers at the university face challenges in continuation of care with the students that we work with. So if they're going home to the home state, we, by law, are not allowed to provide psychotherapy services to them when they're in their home state. We can provide certain crisis interventions, certain maybe referral appointments, things like that. But for many students, that gap in care, which over a summer break can be 3 months, is really, really detrimental to the relationship and the care that they're receiving here. So SciPact would open it up to when our students go home that we're able to continue seeing those folks despite what breaks are happening. And that's not unique to college students. So in Wyoming specifically, we have a lot of seasonal workers. We have folks that are maybe just working here during winter months. They're working at the ski resorts, or just in the summers, and they're working out in the fields and in the forest, right? And so it does apply to a lot of other people that might come to Wyoming for a certain period of time, then go back to their home states. What's been shared, the question about how would you know what state a provider is from, I can answer that a little bit. And so many ways that folks find their provider is through online internet searches. It's just sort of the way it is now. And so a popular one is called Psychology Today. I'm a board certified clinical psychologist, and so the board has a list of providers. We have a number of different ways that you might find a provider that's specific to the concern that you're looking for. And what's required of providers on this site is to identify their home address of the practice, right? So you have to have a primary address of where you're operating from that folks can see. And so they're going to know, at the moment they find you online, and certainly on every single piece of paperwork that you send that to them to fill out confidentiality agreements, all of those things, it's going to have a primary address listed. So they're going to know where you're coming from. Another concern that has come up in the past is the licensing standards. And so if we're having providers from these other states serve our population here, how do we know that they're meeting the licensing standards of the state of Wyoming? I can speak, being licensed in 4 states, is that we have very generous licensing standards here because it's so important that we're able to license people and have folks start seeing clients right away. One example of that is the state of Wyoming does not require an additional postdoctoral training year that many states do require. The reasons for that is that our folks, when they get to the postdoc level, they are well trained. They are ready to see clients. I personally believe it's an additional hurdle that's maybe not necessary. But what folks can do is they can start serving Wyoming populations right away while they're maybe completing a postdoc somewhere else. So an example for myself is that I was licensed in the state of Wyoming while I was completing a postdoctoral position in the state of Colorado. So I was able to get licensed here earlier and then start seeing clients a lot sooner once I then transferred here after the postdoc. So lots of benefits in that way for the providers, but what we know about the people that we work with is it increases access to care, which has been mentioned time and time again. It makes most sense for rural states in particular, who, you see someone in a very small state and there's one clinical psychologist, if they're lucky, in that town, and then that person, is friends with your kids, right? Or it's someone that you know and you're friends with personally. That's really common in our small towns. So you may want to access a provider over telehealth in our state, but you might also want to access someone that's out of state. Maybe they're just across the border. Maybe there's someone that have a specialty area that's not accessible in your area. So we find for certain presenting problems like post-traumatic stress, eating disorders, gender affirming therapy are pretty hard to access in the state of Wyoming. We don't have a lot of specialty providers, and those providers are often full or they're not affordable. And so this allows folks to access providers in other areas. It's part of the reason I practice across state lines is I provide some specialties that are harder for other folks to access. It's been mentioned when people leave and they move across state lines that they can continue to access to their providers, and that goes for folks moving into our state as well. They may have established a connection with a provider in the state they're coming from, and it would be detrimental to change their care over. And even if it's just for a period of time, maybe they're working on transferring to a local provider, but that can take a lot of time. We have wait lists, we have folks waiting to get into care. It's hard to find affordable therapy, and so it can provide that benefit. we've thrown out the number of 34 states, but there's an additional, I think it's 8 or 9 states that have proposed the legislation already. So we could be over 40 states at the end of this year. Conversations that we're having at the APA level is this is the direction that we're moving. I'm confident that every state, with maybe the exception of California because some of their additional requirements, is going to be part of SIPACT. And so I want to see us move in that direction along with the rest of the nation. We also find that, our residents of Wyoming that hold diverse backgrounds are often looking for providers that hold those same identities. Sometimes that can be hard to find in the state of Wyoming. We threw out our license numbers. I'll share another example is I'm 716 or something like that. And I've only been licensed a couple years. So we're probably right around that number because we lose providers every year too. In Colorado, I'm over 5,000. So our number of providers here really is slim for the people that we're wanting to work with. So it's really important for those in our rural areas, those who hold identities that maybe don't match the providers in their areas, those who are trying to access evidence-based care and more specialized services like trauma, eating disorders, gender, particularly important for our transient population. So our students that are here for a period of time, those who are seasonal workers and come in and out, those who have breaks and gaps, maybe they're going home to see their family for a period of time. You can still see that person during that time. Other than that, just one last note about the telehealth portion is we've mentioned that, some folks find telehealth to be less effective. What we found in the research is actually the opposite. So what we found is that telehealth is effective. It reduced costs. It's particularly important for rural and underserved areas. And we found equivalent treatment rates and symptom reduction among a variety of conditions. PTSD included, depression, anxiety, adjustment disorders. And in our youth, there's some recent studies coming out that we're finding similar levels of efficacy for substance use, eating disorders, and other problems in that population. I'll throw out a note of PTSD specifically is at the University of Wyoming. The clinical psychology program here has actually been providing telehealth services for decades. We've been providing, and it's where I train, we've been providing services to rural shelters across the state of Wyoming. And so folks who are in a women's shelter, in an IPV situation, can go to that shelter and receive therapy from graduate students at the University of Wyoming. And we've been doing that before telehealth was mainstream, before SIPACT even exists. And there is some research out from that pilot program that we're seeing the same rates of reduction in PTSD, depression, improved life satisfaction. And that data has been out for a very long time. We now have lots of data coming in on telehealth in general that's showing it is just as effective and it can improve access to care. I think those are my primary notes. I'm very happy to answer any questions. And that's all I have. So thank you.
Thank you very much, Doctor. Questions for the doctor committee? Seeing none. Anything further, Dr. Benson, Dr. Hackman? You're not green yet, sir. You're still red, but you got nothing more. Okay, they heard me say it. You got nothing more. Okay, very good. Any further questions, committee, before we let these gentlemen go back to the same comfort of the seats that they're in right now? Okay, thank you very much. That being said, let's move on to public comment, please, on both of these proposed bills. If you have public comment, please feel free to jump up here and sit in a seat. There's 4 seats. We don't want them to go vacant for too long. A familiar face at the table. Go ahead and reintroduce yourself and go ahead and speak.
Thank you, Mr. Chairman. Andy Somerville, Executive Director for WAMSAC. My comments on this topic will be brief as they've been discussed before during previous legislature. The Wyoming Association of Mental Health and Substance Abuse Centers supports both of these compacts as they are. We feel that they've been through a good vetting process with their associations. We vetted it through our directors. And of course, we're in the unique position of employing all of these different trades: psychologists, psychiatrists, counselors, social workers, the whole 9 yards. And we feel that it's necessary. Just touching back to the topic that we talked about before lunch in terms of workforce. This is another tool in the toolbox. We really need to use the tools or provide the tools that we can so that we're helping people stay established in rural areas and letting them practice telehealth out of state if that's the case, or the vice versa is in areas where we are in dire need of clinicians. Telehealth kind of intermittent help is appreciated. And frankly, it's something that a lot of the providers have had to do over the pandemic to fill in gaps. So again, we stand in full support, and I'd be happy to answer any questions.
Questions from Ms. Somerville? See no hands waving, you're off the hook. Further public comment? Anyone else wish public comment? Anybody online? Nobody online, calling once, calling last time. Public comment is closed. Committee. We have a decision to make here. You have two bills from previous sessions. What we would need to do and what would be my preference if someone would so like to make that motion, that we take both of these bills. They've been vetted thoroughly in previous sessions, especially in the Senate. Is that we move both these bills forward to LSO, have them create the proper format with the proper numbers, proper dates that have been suggested, and that we hear those formally as a bill at our next meeting. Comments, committee? Go ahead, Chairman Wilson.
Thank you, Mr. Chairman. Just for LSO's reminder, and I agree with you. So both bills have effective date issues. So on the previous Senate File 54, we have on page 68, there was a request to make it effective immediately. And then Senate File 37, which is the SIPACT, on page 73, we have an effective date, which I think we may as well also make effective immediately, just to have them the same way. So I just point those two out. I'm sure LSO would catch them, but for our recollection too, but that's my only point.
Any further discussion? Representative Conley.
Mr. Chairman, I would assume that that was a motion to move these forward, and I would second it then.
Motion and second. Further committee. All in favor, say aye.
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 Opposed, say no. That passes, and we'll move that on to LSO. We will see those both again in October and formally work those bills. Thank you very much, committee. We're ahead of schedule. That's
What committee
shocking.
is this?
It's shocking. That brings us up to our final topic, which would be alternative treatment to substance abuse disorder. Mr. Mendoza, is he nearby or online or up? I believe he's waiting in the foyer. This is a presentation that I have seen. I thought it of sufficient interest that the committee should hear this. I think it's an interesting solution and something that may require some legislation to enable in the state of Wyoming. But we welcome Mr. Mendoza, who's traveled. He can tell us where he traveled from, but something new to the state of Wyoming. Come on up to the table, gentlemen. Yeah. Gentlemen, if you push that button, a little green light will come on there. There you go. Please introduce yourselves and go ahead and address the committee. We've talked before,
Yes.
so go ahead.
Thank you, Mr. Chairman and members. Mark Mendoza, I'm the Director of State Government Affairs for Pear Therapeutics, and we're very excited today to talk to you about the two only FDA-authorized prescription digital therapeutics that treat both substance use and opioid use disorder. Before I hand it over to my colleague, Scott Scheppers, it is important to note that these FDA-authorized apps on your smartphones and on your tablets are complementary tools. So these are tools that prescribers or clinicians, nurse practitioners, anyone with prescribing authority use as a complementary tool towards addiction treatment. Currently, right now, we are working in 10 other states. Most notably, Massachusetts and Oklahoma have made this a value-based Medicaid benefit for their patients, but we're also working in states like Ohio, Indiana, Kentucky. I could go down the list in terms of where we're working, as well as 3 Native American nations as well. And lastly, in the criminal justice system as well, to make sure that those individuals have access to addiction care. So with that being said, I'll hand it over to my colleague, Mr. Scheppers, to start the presentation.
Hi, everyone. So just as a bit of an introduction, my name's Scott Scheppers, and I am the head of field medical affairs at Pear Therapeutics. So I'm going to walk us through a little bit about the therapeutic, a little bit about the background, and then some information about the clinical data, some of the other clinical trials and analyses that we've conducted related to these therapeutics. So on the first slide that you might see here, we're showing some of the safe harbor statements and some of the disclosures related to the content in the presentation today. But I think we want to start with understanding a little bit about the space and a little bit what we've seen in the most recent years related to some of the trends around digital health and well-being. So we certainly have seen a major increase in the disease burden. So especially in terms of mental health, we've seen growing cases of substance use, of opioid use disorder, of depression, anxiety over the past several years, which have all happened in the context of shortages in mental health care providers. So we've seen growing shortages across the country in rural locations and urban locations. So we've been looking to new options, new opportunities to treat these patients who need services but can't access them. And so one of the ways that we can turn to that is through digital technology. And we can do that because technology is pervasive. I have an Apple Watch on my phone or an Apple Watch on my wrist. I have a watch or a phone in my pocket, and we use it a lot. On average, as you'll see on the slide, patients use their phones on average about 5.5 hours a day, which is a pretty surprising amount, actually. We've already seen some of this. We've seen transitions to telehealth and telemedicine over the past several years, which really were pushed forward through the COVID-19 pandemic. So looking back a couple of years ago, we've seen more than 100% increase in patients who indicate that they've received mental health services via telemedicine or telehealth. I don't see that going away anytime soon. I think patients like receiving their healthcare virtually when it's appropriate. I think providers like providing care virtually when it's appropriate as well. So in the context of the telehealth and the digital health revolution, we've also seen an increase in the number of digital health applications that are available to patients as well. A 2021 IQVIA report found 350,000 digital health and wellness applications available on the app stores cumulatively. So the Apple App Store, the Android Store, which is great. It's great that patients have all of these options. However, it puts a burden on the provider to understand which ones of these options are safe, which one of these options are effective for patients who need them. So that's a little bit what we're going to talk about today and some of the thinking behind a prescription digital therapeutic and the FDA authorization that provide evidence for its safety and efficacy. We're going to switch gears a little bit to talk about addiction. And so I'm going to talk about what addiction treatment looks like nationally and what some of the national treatment organizations recommend in terms of addiction care. So we have, as I mentioned, a growing addiction problem in terms of patients having SUD, in terms of deaths associated with substance and opioid use disorders. But we have effective treatments. We have effective treatments in terms of pharmacology. We have effective treatments in terms of behavioral health services. And specifically on the slide you see, on the document that you see in front of you, we talk about some of the major health organizations, SAMHSA, ASAM.
One pause, let's just make sure we coordinate what you're saying with the slides.
Oh, sorry, I will let you know. You can go forward to the next slide.
Okay, there we go. Go ahead, sir.
Perfect. Thank you very much. So this slide is showing some of the statements from different national treatment organizations or groups, including the American Society of Addiction Medicine, the Substance Abuse and Mental Health Services Administration, and the Veterans Affairs Department of Defense. And so they're all calling out the benefits of cognitive behavioral therapy and the fact that it's a critical component of addiction care. So in addiction care, cognitive behavioral therapy in some instances provided alongside medication treatments, pharmaceuticals, that are approved for certain disorders. So opioid use disorder, alcohol use disorder, there are prescription drugs that are FDA approved to provide treatments for these patients. So in that case, it would be an adjunct to a medication. In the case of substance use disorder, including cannabis, cocaine, stimulants, these patients don't have a medication option. There's not an agonist or an antagonist treatment out there that's FDA approved for these patients. So these types of treatments, cognitive behavioral therapy, we're going to talk more about contingency management, really are the gold standard evidence-based care for those patients. So the next slide you'll see really emphasizes some of the shortages that we see across the country. So on this slide, we see a map of the United States broken down across counties. The darkest shading of the map represents counties that have a shortage, an entire shortage across the county in mental health service providers. The middle shading represents counties where only part of the county is in a shortage area. The lightest shade represents counties where there is not a shortage of mental health service providers. You can clearly see that the lightest shades are very infrequently represented across the figure. When we look in the state of Wyoming specifically, we can see that most of the county, like most of the state, like most of the other states in the country, are in counties, include counties that have a complete shortage across the entire county of mental health services. So that is really what brought upon this digital health, these digital health applications, and specifically prescription digital therapeutics. So on this next slide, it says, what if we could meet patients where they're at via an FDA authorized application that they could access via a smartphone or a tablet that could actually have impacts on clinical outcomes. So the clinical outcomes we're going to be talking about today are abstinence and it's treatment retention. So treatment retention refers to keeping patients in treatment for longer, keeping them engaged in their clinical care for longer periods of time. The more we can do that, the more likely clinicians are to make impacts and to see some further positive outcomes down the road. So on the next slide, we talk a little bit about what a prescription digital therapeutic is. A lot of us are familiar with prescription drugs, we're familiar with digital therapeutics, but when you put them together, it's a little bit confusing. So I think one way to think about them at a high level is as a new evolution, a new type of treatment that is simply being introduced to patients. So going back 100 years or so, 150 years, we saw the introduction of small molecule drugs. More recently, we've seen biologic treatments, we've seen cell and gene-based therapies be introduced to patients. And now we have digital therapeutics, which are very different in some senses. These are treatments for disease delivered via a piece of software rather than delivered via an injection, via a pill, or an infusion. But in the other sense, they're very similar. These go through regulatory processes. These are therapeutics designed to treat serious disease that are backed by evidence. So when we look at the table represented on this slide, we see some ways that we can think about these different categories: digital health and wellness, pharmaceutical drugs, and prescription digital therapeutics. So like a health and wellness application, prescription digital therapeutics are designed to improve human health. And this isn't to take anything away from a health and wellness application. I use health and wellness applications all the time to track my health, track my steps, track my heart rate. I think many of us probably do the same. But they don't deliver a treatment, they aren't backed by evidence, they aren't reviewed by a regulatory body. So that is where prescription digital therapeutics and pharmaceuticals are more similar. So these are required to be tested in clinical trials. They are indicated as approved or effective by the FDA to validate the safety and efficacy demonstrated in clinical trials. This allows them to be reimbursed via pharmacy and medical benefits by payers. The one thing that's unique about a prescription digital therapeutic that we see on the very bottom of the table is the fact that a PDT, which is short for prescription digital therapeutic, provides real-time feedback to clinicians on patients' use, patients' engagement, some of the outcomes they achieve. So if you provide a patient with a pill for a blood pressure, provide them with a blood pressure medication, you might not know whether the patient's using that medication, whether they're seeing any benefits to their blood pressure until they come back into the clinic, or they should happen to call the provider. In the case of a prescription digital therapeutic, the patient leaves the clinic, they're providing real-time feedback and engagement information. The provider and the care team know that the patient's using it. They know some of the benefits that they're receiving it via the data that the patient's providing to them. If we go to the next slide, we're actually going to start talking about these therapeutics more specifically. So on this slide, on the left, we see Reset. On the right, we see Reset-O. And this is looking at the indications for use. So these are indications that were provided by the FDA on the basis of the clinical data that I'll cover very briefly in the coming slides. So I'm going to walk through the indications for use for Reset on the left, just so everyone understands. Reset is intended to provide cognitive behavioral therapy as an adjunct to contingency management system for patients 18 years of age and older who are currently enrolled in an outpatient treatment under the supervision of a clinician. Reset is a 12-week, 90-day prescription only for patients with substance use disorder who are not on current opioid replacement therapy, who do not abuse alcohol solely, or do not use opioids as their primary substance of abuse. So the indications below indicate that Reset is indicated to increase retention in a patient's abstinence from substances during the course of their treatment, and also to increase their retention in their outpatient treatment program. Reset-O on the right is similar in a lot of ways, but is different in terms of the labeling in the sense that it's indicated specifically for patients who have opioid use disorder. It's also indicated to be used alongside patients' buprenorphine medication, so opioid agonist treatment, opioid replacement medication. The other difference here is that Reset-O is indicated specifically, I already mentioned that, specifically for patients using transmucosal buprenorphine, right? The indications for Reset-O are to increase retention in the patient's outpatient treatment, so keep patients engaged in their outpatient therapy for longer durations of time. The next slide that we can move to here is talking about the mechanisms of action. So what's the meat? How does this work? What are the therapeutic modalities integrated into it? So there are three. This is an addiction-specific cognitive behavioral therapy, a fluency training, and a contingency management system. So starting from the left, I'm going to walk through this to help us understand kind of the patient journey through the digital therapeutic as I'm walking through the modalities. So this is, as the patient's using the therapeutic, they're working through a series of lessons or modules, 61 or 67 modules that are the patients work through, that take about 15 to 20 minutes for them to complete. They work through these in a 4-lesson per week capacity. We can think of that as the dose. The dose is for patients to complete 4 lessons per week. This is focused on an addiction-specific type of cognitive behavioral therapy called the community reinforcement approach. This is not a type of behavioral therapy that my company developed. This is a type of behavioral therapy that's been around and studied going back to the 1970s and 80s and has been found effective in the treatment across a variety of substance use disorders. One of the unique features of the community reinforcement approach is it's focused on helping patients to learn about some of the natural and some of the non-drug rewards that they can earn when they start to live a healthy and drug-free lifestyle. So when we think about these types of rewards, we're talking about social rewards, social reinforcers. We're talking about things like self-efficacy that patients can start to receive when they begin to live that drug-free lifestyle. So there are lessons inside the therapeutic helping patients to build and rebuild relationships that may have suffered through their substance use. There's lessons on communications and vocational skills that can help patients to establish self-efficacy and stable housing throughout the therapeutic. As the patients complete those lessons, they then receive a fluency training. So the fluency training is an evidence-based learning program. It's designed to help patients retain the information that they've learned, but also to demonstrate and to make sure that the patients are mastering the material before they move on to subsequent lessons. We want to make sure the patients learn earlier lessons before they move on and learn later ones. When the patients complete a set of those, when they complete a lesson and demonstrate that they've mastered it, or when the provider enters the results of a negative urine screen demonstrating abstinence for that patient, they then enter the contingency management system. So contingency management is a highly evidence-based positive reinforcement system. It's used but really underutilized across the country in substance use and opioid use disorder. Typically, patients receive vouchers or gift cards when they perform treatment consistent or treatment appropriate behaviors. So in the case of Reset-O, patients earn the opportunity to earn these rewards when they complete lessons, demonstrate mastery, or provide evidence of abstinence through negative urine screens. So that is all included, all integrated into the therapeutic and governed via the wheel that you see on the slide here. So the patient would press the wheel upon earning an opportunity. It would land on one of two outcomes. Some instances, the patients would receive a virtual reward. Way to go, good job, keep up the good work, motivating them to continue with their therapy. In some cases, the patients would receive the opportunity to earn a gift card or a value that they can apply to a gift card. So these are integrated into the therapeutic, and the patient can choose from 17 different vendors across a variety of retailers where they can choose to receive an online or an in-store gift card. On the next slide, we look at the randomized clinical data for these two therapeutics. So on the left, we are looking at a study of Reset. And so both of these clinical trials were conducted independently from Pear Therapeutics. The study on the left was conducted through Dartmouth University and through NIDA and the NIDA Clinical Trials Network. So these patients were treated through the National Institute of Drug Abuse CTN sites, of which there were 10 at the time. And these were two groups of patients. So there was a patient group that received treatment as usual, which involved 4 to 6 hours per week of face-to-face counseling with a provider to receive their care. The other group received reduced treatment as usual, plus access to the digital therapeutic. So the study was designed in a way that they would receive 2 fewer hours on average, about 30% fewer hours with their clinicians, but they would also have access to the digital product to account for that time. In the outcomes that we see on the left, the first is abstinence. We saw a little bit more than twice as much abstinence over the final 4 weeks of that clinical trial. So this was a total of 40.3% in the treatment as usual plus reset group compared to 17.6% in the control arm. In terms of retention, this is looking at patients' overall compliance and attendance with their clinicians for their clinical care. We see a 13% improvement in retention, 76.2 to 63.2%. For Reset-O, which we see on the far side, on the far right side of the slide, this is looking specifically at patients with opioid use disorder and was looking at a study conducted at the University of Arkansas Medical Science Center. This study included patients in a treatment as usual and a treatment as usual plus Reset-O or plus digital therapeutic group. The only difference between the two groups in this study were that patients in the digital arm had access to the digital cognitive behavioral therapy content. Okay, so patients in both groups were receiving contingency management through a fishbowl technique that was delivered for negative urine screens. Both groups were receiving buprenorphine to support their substance use. And in this study, we found a 14% improvement in clinical retention among patients that had access to that digital CBT content. So there's a very high level on the 2 randomized clinical trials. If we go to the next slide, we actually see some of the outcomes that we've collected from patients using the therapeutics in the real world. And so what we see on this slide on the left is showing that about 65% of active patients are completing those 4 lessons per week. So they're complying with the instructions with the recommended dose of Reset-O. On the bottom left, we see that more than 30% of, that patients are spending on average more than 30 minutes per week inside the therapeutic. And I think interestingly, which maybe isn't surprising to folks, if we look on the right here, we're seeing that patients are accessing this therapeutic at all hours of the day. So even in hours where you wouldn't be able to visit a clinic, even if you had access to one, the patients are using the therapeutic. About 88% are using the therapeutic in non-clinic hours, and those are between 7 p.m. and 9 a.m. On the bottom right, we see that about 68% of patients, or more than 68% of patients, are completing 7 or more of those sessions over the course of their clinic. So they're using the therapeutic in times when they need it but couldn't access a clinic, even if one were available. The next slide is showing a little bit more of what we've already covered. So this is showing and just emphasizing that there are 2 sides of these digital therapeutics. On the left, we see the patient-facing side delivered via mobile phone or a tablet. And on the right, we see the clinician side. So this is accessible by the prescribing doctor or by the clinical care team as appropriate to view the patient's interactions, engagement, and clinical outcomes as they move through care. And so we've talked about the way the therapeutic works. The 2 things we didn't mention on the left is there's an opportunity for the patients to report in real time on some of the drug cravings and drug urges that they have, and then some of the triggers, so some of the physiological or psychological states that in many cases accompany and in some cases drive those triggers and cravings for the patient. And it also tracks, in the case of Reset-O, tracks the patient's use of their buprenorphine medication and their compliance with that buprenorphine medication, and makes that available in real time to the clinic so that they can understand that as well. On the next slide, we're talking about privacy and security. So that's an important part of this. So we want to make sure that what we're providing to patients is secure, that their digital information, that their patient health information is kept safe and secure. And that's exactly what this PAIR platform is designed to do. So this aligns with SOC 2 and HIPAA compliance standards and uses industry recommended algorithms to protect data that's in transit. We do not share PHI or patient health information with third parties, and the privacy practices are disclosed to the patients and on the PAIR website. So the patients are always disclosed and provide and obtained written consent as to their use of their data and the sharing of that data back with the healthcare providers. So patients understand exactly how the therapeutic works and exactly where their data is going. And on the next slide, I'm going to finish up by talking a little bit about some of the other data that we've collected and collected more recently. So we can think about data in different ways when we're talking about data that support the use of a prescription digital therapeutic or a pharmaceutical or any treatment that's intended for patients. We look at the randomized clinical trial data. These data are really what we think about as the gold standard of care. So this is really the gold standard evidence that we use to submit data to the FDA. It looks under tightly controlled conditions at very objective outcomes. Real-world evidence and health economic research takes those data, it takes data collected in the real world and helps us understand how those clinical outcomes relate to some of the benefits that we see in terms of use of the healthcare system, in terms of the costs associated with that. And so that's what I'm going to share on the next slide. I'm going to start by sharing some of the earliest data we collected related to Reset-O. And this data was looking at a patient population of about 334 patients that received Reset-O as a part of their clinical care provided by their provider across the United States. So what we did in this analysis was we took a index date, that was the date where the patient was prescribed the medication or prescribed the therapeutic. We looked at the 6 months before that prescription, and we looked at the 6 months after that prescription, and we determined whether the healthcare utilization, whether the costs associated with that care changed. And what we found is detailed below. And so we found a shift in the way that patients are using the healthcare system. Patients were using less costly and intense services like inpatient stays, emergency room visits, and surgical procedures. But we saw an increase in the way that patients were using case management and addiction treatment services. And when we put that all together, when we look at the total cost of care, we see a reduction of $2,150 in the 6 months after patients received their prescription compared to the 6 months before. We've looked at these data here at 6 months. We've looked at outcomes at 12 months in a slightly different way. The 12-month data we've collected show even greater savings, about $2,700 in savings, and compared to a control group of patients who were prescribed the therapeutic but didn't use it. And again, this is looking at Reset-O. We've also looked at Reset, the therapeutic for substance use disorder, over these 6-month time periods and seen savings in the neighborhood of $3,000. I'm happy to provide these data to folks as a follow-up in terms of their published sources. So that's what I have for high levels on the clinical. I will pass over to Mark for.
Thank you, Scott. And so also on the next slide, when we see what federal agencies are currently saying about this, the Office of National Drug Control Policy this year released their strategy document. And specifically within that document, they talk about prescription digital therapeutics. While Reset-O is not called out by name, it talks about a 2018 prescription digital therapeutic that complements buprenorphine that was approved by the FDA, and specifically talks about how tools like this could help increase services for a wide array of patients. And specifically within that calls out a recommendation for legislative bodies to explore potential reimbursement for these type of tools to make them available for patients. On the right side of that slide, you will also see SAMHSA, which is the Federal Substance Abuse Agency under HHS, talk about emerging practices. And specifically within that page, they talk about our Reset-O tool for opioid use disorder. But also last year, when SAMHSA was putting out guidance on how to spend ARPA substance abuse block grant funds, the first bullet that the acting secretary called out was developing and expanding the use of FDA-approved medications and digital therapeutics as a part of addiction treatment. So again, what you're seeing here is a good amount of federal agencies that are sort of rallying behind these tools and trying to figure out how to get them into the hands of patients. Now, for our last slide, I wanted to provide just a very rough policy proposal for potentially the committee to consider. So because FDA authorized prescription digital therapeutics right now are not robustly covered by commercial health plans, so the Blue Shields, Aetnas, Anthems of the world, and because Medicaid doesn't have a benefit category right now, in the 10 other states we're working with, they've had to put funding up to make sure that these prescription digital therapeutics are available for patients. And that's been done through state opioid response grants, which are given from the federal government every 2 years, through ARPA substance abuse block grants, opioid settlement dollars, and in very rare cases, general fund monies. So based on the data that SAMHSA reported last year, currently Wyoming has 60 substance abuse treatment facilities currently within the state, and reported a total of about 3,800 patients that were currently enrolled in outpatient treatment facilities. Over 80% of those substance abuse treatment facilities also provide telemedicine and telehealth services. So again, enabling and broadening access to addiction treatment services for patients. So with that in mind, we were sort of looking at a potential pilot, if the respectfully, to look at working with patients of about 1,500 patients, so about 40% of the current patients right now, and adding about 400 refills also to that. As we know, recovery is not linear. Now, again, this is a very rough estimate. I mean, you know, we would be honored to partner with the state of Wyoming to serve patients in any capacity at any scale, but this type of total of a project would be around $2.8 million. And again, this tends to be on the lower amount of the projects that we've worked with currently in other states. So again, just wanted to, again, respectfully propose a potential pilot program for the committee to consider. And with that, Scott and I are happy to take any additional questions on the material presented today.
Thank you very much. Questions, committee? Representative Conley, go ahead, ma'am.
Thank you, Mr. Chairman. And so I'm trying to get my head around this, and so forgive me for this analogy, but I recently had orthopedic surgery. Okay, so I've had a knee replacement. And I honestly have one of these apps, which is a ZB My Mobility. It stands for Zimmer Biomet, that my surgeon prescribed, if you want to call it that, for me. And I'm sorry if it bothers you guys, but it beeps at me to go do my exercises. But it begins every day by asking me about my pain, whether or not I'm using prescribed opioids or then over the counter, and I put in ratings for my pain. And the one time I kind of increased it from one day to the next, the surgeon's nurse got back to me and said, "What's going on?" I mean, which really surprised me. I didn't realize it was that live. Okay. As far as I know, I'm not paying for this, or my insurance company isn't. It's part of my post-operative surgical, my surgical post-op. And so I'm curious about this thing I have on my phone that tells me to go exercise, but honestly does some, I think, good monitoring of me. And what you're suggesting, it seems to me that it's comparable. I mean, mine's orthopedic. This is kind of substance abuse. It requires, in my case, a surgeon. In your case, a clinician sends information, probably bothers the patient 3 times a day, but you are required. So I guess my question is, how is my surgeon, if that's the case, or my insurance company, or me, paying for this? Or is it just part of the treatment? And if that's the case, why isn't this just part of the treatment that a clinician has available to him or her for a substance abuse patient?
Gentlemen, go ahead.
I can take part of that question. Thank you for the question. So I think one way to think about it, and I would have to do some research on the application that you're using, but the way that you're describing it is this is a tracking application. So it's tracking your use, it's monitoring, it reminds you to do things. I think the difference between this and a prescription digital therapeutic is that these actually provide a treatment. So these are providing a treatment that's evidence-based, that is delivered in other formats around the country, but not digitally. And so if you were receiving this treatment outside of the care, you would be paying for it. This digital therapeutic is delivering this care, has been through the FDA, has been approved authorized to provide this treatment. But I think that's the biggest distinction, is the fact that it's a treatment versus a tracking application.
I didn't mention that really what it's bothering me to do is my exercises. It's PT, and it has actually videos on it of what I am supposed to be doing. So it is treatment.
Go ahead, Mark.
Yeah, I mean, I would just add, I would, again, just echo what Scott mentioned, but I think as well when you have these motivational incentives that are a part of contingency management, right? We, as a company, pay for that as a part of the regular tool, right? We also, in the sort of general price for the prescription, we are training providers, we're working with the state, we're also providing cognitive behavioral therapy, right, as Scott mentioned, via the app, to offer this tool for free that, again, is prescription-based, I think, as a business model is not sustainable to paying also these incentives out just, without a cost that's primarily connected to that. But again, I would echo Scott's comments that, again, these tools are meant to treat, severe diseases and disorders as well.
The other thing I would add is, again, I mentioned I'd have to understand more about your therapeutic. I'd be very surprised if it was a therapeutic that no one is paying for. I would imagine it's a part of care, or it's been licensed by your treatment provider, licensed by your insurer, something like that. That happens with many digital therapeutics. Sometimes they're licensed through a payer, licensed through a healthcare practice, and they are able to provide them to patients. So they cover the upfront cost and bundle them into a package and make them available to patients. So that's certainly a possibility. I don't know of any therapeutics that have gone through the FDA authorization and would be considered prescription digital therapeutics that are bundled in that way today, not that I'm aware of anyway.
Chairman Wilson.
Thank you, Mr. Chairman. I want to apologize. You guys were chasing me all summer to try to present to me. And going to my schedule, I think I even put you on my schedule once and then I didn't show up. And so for the committee's sake, I just wanted to say that this is the first time I've actually seen the presentation because I kept not really showing up. But I want to say really interesting. It's so familiar to me, oddly, because in my day job, I have a translation business, and one of my main clients is a Spanish developer of prescription digital therapeutics. So the European Medicines Agency and all these sort of things, I'm constantly translating documents really just like this. And as a matter of fact, I'll take this home and I might use it as a language resource. But my point in bringing that up, committee, is because I think it's important for us to understand that this is not just some kind of random sales job of an untested product that might be falling up. What sucker can they find to do this? I mean, pardon my, but these digital therapeutics, I mean, I've been working on products along these lines for a number of years now with my client in Spain. Personally, if we can, I know we have some unassigned ARPA dollars for next year. This is not a large sum of money, and considering our very high substance use rate in this state, I think this could be a really great tool. It's because of our lack of broadband and cell coverage, it's probably not going to help the, middle-aged rancher out in the boonies because he won't have any connectivity. But it could, I think this could be a really great tool. I think personally, I think it's worth investigating of having the governor's office look into using this fund to be part of a pilot project with the thought that, we have, for several years, we've been trying in Wyoming to maybe position Wyoming on sort of I hesitate to call it cutting edge, but as a leader in rural health. And the ability to use telehealth and that kind of thing. I know the university is looking at that. We had that bill a couple of years ago on innovation grants, which we don't have enough money in that pool to fund this, but I won't be here in January, but I really would, on initial reading, speak very favorably of something like this. And as I say, this is not a totally random, whoever heard of this strange thing. I mean, we may not all have, but it's was amazing to me as I was reading this, how much this is, I think, it really in the mainstream of where this kind of tool is going. So thank you. And wouldn't you agree? We're supposed to ask a question.
Thank you, Chairwoman. No, and I appreciate that we share the same passion for PDTs. And I'll just note as well, since you mentioned additional languages, this tool is also available in Spanish, and it has functionality that has actually helped break down some of these equity and accessibility barriers by the CBT chapters we're talking about here can actually be downloaded on your phone when you're connected to Wi-Fi or a hotspot. So if you do end up living in a more rural community that may unfortunately lack access to broadband, you can still move through the therapy on your phone offline. So again, that's been very exciting and helpful for a lot of rural communities that we're working with right now.
Very good. Further questions, committee? This is a very tired committee. Senator Hutchings, are you raising your hand or are you just waving at us? Oh, you're just waving. Okay, it's good to see you too. Committee, further questions for these gentlemen? Go ahead, Senator Furphy.
Thank you, Mr. Chairman. Well, let me ask about why you're looking at Wyoming. Our population base is pretty small when you're trying to develop a product like this. So, why did you pick Wyoming? Thank you.
I'll take it for, yeah, I would say, whether we're talking about big states like California, Texas, Florida, New York, or states like Wyoming and Oklahoma and Alaska, we want to make sure every single patient in the United States has the best fighting chance at recovery, right? And we understand, regardless of community, where you may live, we know overdoses, right? And specifically individuals that are unfortunately overdosing from fentanyl, right, is hitting everywhere across the country. So at this point, we are touching base with every single state, regardless of size, to make sure, again, we make the case to folks at the state level, at the provider level, at the local level, that this is a tool that can really help patients not only stay engaged with their treatment program, but again, data that we have that supports abstinence in the long run. So.
Go ahead, Representative Conley. That's our biggest test, is pushing the button.
Thank you. Okay, so this is prescription, thank you, Mr. Chairman. So this is prescription-based, and in Wyoming that our licensed professional counselors and our psychologists cannot do prescriptions. And most of our substance abuse treatment, in the way that you're talking about having a clinician kind of available, is done by those who are not able to do prescriptions. And so how does that work?
Yeah, so for example, we've heard this same issue in other communities, specifically in Oklahoma, right? Because we know, again, there is not a robust healthcare workforce that's out there in terms of a clinician or prescriber being available at every single treatment facility. But what we have found is that clinicians may move across the United States or across the state from time to time, right? And so a workaround for some of these workforce issues that we're seeing across the US is standing orders that can be put at these different facilities. So what that looks like is if I'm a doctor, I can tell my nurse practitioner, administrative assistant, right? If you are seeing these symptoms that a patient is exhibiting, you can write a prescription for Reset or Reset O under my license, right? And so those standing orders, for example, in Oklahoma, have been used at quite a few facilities to make sure that these tools can actually be prescribed and used by patients. And again, even if the clinician's not there, again, that nurse that may be there is typically the one that's monitoring the dashboard and providing notifications, similar to how you may be receiving notifications from your nurse or your physician that, hey, I saw new activity on the application, or you didn't complete your CBT module. So again, while the prescription is important, we have been creative in terms of figuring out a workaround so that patients can access this while also continuing treatment as usual with their regular provider, whether that's a nurse or someone that does not currently have prescribing authority.
Representative, I will tell you as a clinician, I have preferences to what was described. And I think there's some other workaround. And although you won't be here next session, I happen to know that there's another piece of legislation. We're going to discuss this more. But I think there's other workarounds. And I always encourage my patients on antidepressants, opioid treatment, et cetera. I think it's important that they work with a team, with the pharmacist, with their provider, be it their nurse practitioner, their doctor, their PA, whoever, their clinical psychologist. It needs to be a team effort. And I think it's important to have a practitioner, a clinician, a part of that. But you're hearing my own personal bias now, but I think it's certainly workable. I'm not a big fan of standing orders, but that's my personal bias, and you'll hear more about that. Further questions, committee? Representative Flitner is not waving at us. She's just hot and fanning herself off. Okay, thank you very much, gentlemen. We'll let you have a seat down further, and we'll get some public comment, hopefully.
Thank you.
Go ahead and have a seat back in the comfortable chairs. Welcome back.
Thank you, Mr. Chairman. Again, Andy Somerville, Executive Director for Wyoming Association of Mental Health and Substance Abuse. I will start by telling the committee that the first I learned about this was a few weeks ago when these lovely gentlemen called me. And so we've been on a learning curve for a few weeks, and I think that's going to continue for a while. So what we've done is send this information out to all of our directors. As this committee is well aware, the WAMSAC providers provide a lion's share of substance abuse, certainly in terms of IOP treatment in the state. And so this is very interesting. Again, you guys are not, you've heard me say before that we have sometimes difficulty in rural counties in terms of providing the necessary services. So say like an IOP group that's only women or only men, because we just don't have the economy of scale. And so what's intriguing, at least to the providers for WAMSAC, as they've looked at that, is this another tool that potentially could be put into use? They are certainly looking at that, and we're going to have some more conversations with this group in the next coming weeks, have them come out, meet with the directors and the staff, and do all of that fun stuff and kind of go through it. I would mention we certainly do have a lot of questions about how we would put into practice the prescription, actually logistically getting that going. Community mental health centers, generally, let me make sure I'm right. I believe none of them actually have a full-time psychologist on staff, or psychiatrist, excuse me, on staff right now. Most of them use APRNs in the community or are contracting elsewise with third-party companies that are out of state to provide medication management. There are a few exceptions where primary care providers work with our clinics, but we're still working on that issue of trying to get more primary care providers to come help us out. But we do have some questions along that, and we certainly want to make sure that it is a tool that is not only clinically appropriate, but that it can be used, right? I think one of the first questions I asked them was, well, it's Wyoming, and broadband and internet is not everywhere in this state. You know, we can't be giving somebody a prescription for something they can't use. And what I'll say is that these gentlemen have been very helpful so far with information and answering questions. So I guess what I would like to tell the committee is we are looking into it. If there's a potential partnership with the community mental health centers, we're going to figure that out here soon. And I'd stand for any questions, Mr. Chairman.
Questions from Ms. Somerville? Thank you very much. That should be the last time you have to get up to that chair.
I think so, sir, for a
Unless you
couple of
want to come
months.
back for some other committee. Further public comment? Seeing none in the room, is anybody jumping online? Oh, Dr. Hallinan, go ahead, sir.
Mr. Chairman, thank you. I have a question for these gentlemen here. I noticed that you exclude alcohol from your program. I wonder why that is, and is there a plan to institute an alcohol treatment program in this area?
Mr. Shepherd, go ahead.
Hello, I think I'm on now. Okay. Thank you for the question. So it's not necessarily excluded. So this goes back to the clinical trial data that I talked about. And so the unlabeled indications are when it's alcohol, the indication is for alcohol and another substance, right? So in the clinical trial that was conducted through NIDA, National Institute for Drug Abuse funded, they were not allowing alcohol use disorder only patients. So patients enrolled in the trial needed to be using alcohol and cannabis or alcohol and stimulants or something else. So that is why we see that in the indication. Certainly in the real world, we see providers prescribe reset for patients with alcohol use disorder based on their professional discretion, but that is an off-label or a not consistent with label indication. In terms of future development and research, we are currently and have received in the past 6 months, have received breakthrough designation on alcohol use disorder specifically application, and that's currently undergoing clinical trials and in the development phase right now. But thank you for the question.
Further questions, committee? Seeing none, thank you again. No more public comments. Public comment is closed. Committee, any directives for LSO or anything you have on your brains about this last topic? Go ahead. I suspected you might, Chairman Wilson.
Thank you, Mr. Chairman. I would at the very least like to have this on the October agenda again and hear from WAMSAC about what their feedback and further discussion has been. And as the fall goes forward into the sort of the pre-appropriation season, we can maybe hear from the governor's office what thoughts they've had as far as, this next round of ARPA dollars. If that's a source, and I don't know, we might hear from the Department of Health if there are other funding sources out. But, I admit it's new and it's different, and so that's always a little bit like, But as I say, we've heard the information about the clinical trials. I mean, it's a regular clinical trial process, just like any other, some sort of medication. So, just because it's different doesn't mean it's just some sort of random one-off of a couple guys in the garage. Which perhaps was a sort of an initial fear, right? I mean, anybody can do a nice colored brochure, right? But to get through clinical trials takes a little bit more a level of investigation and all. So I think that we have an opportunity to maybe have a breakthrough. The results from the initial results on the percentage changes in behavior, I think are, significant considering the problem that we have in the state. So, they're not paying me to say this. So I never saw them before, but I would like to just spend some more time again in October and see where we're at.
I think that's a wonderful idea, and I would add to that I know the Department of Health is listening to us. I'm sure they are. They listen to everything we say. They don't always agree, but they listen. And I happen to know that somebody from the governor's office is listening because I've been watching her shake her head back there. So that if for the October meeting that they're aware and perhaps can prepare some statements for us or more ideas or more knowledge concerning perhaps the ARPA dollars, et cetera. Okay. Committee, now we've closed out that topic. Do we have any, well, let's actually ask staff, what do you have for directives from us right now? And we'll tell you what we missed.
Mr. Chairman, as to the first topic, the PRTF topic, you asked for a bill draft that authorizes the Department of Health to work on pursuing a UPL for PRTFs with the legislative and to include that the legislature's intention was that the Department of Health can spend UPL revenue to draw down federal funds to benefit these PRTFs. And then you sponsored the postpartum extension bill draft as amended. As to the funeral practitioners, you want a draft bill regarding their language. As to the coroner topic, you want to draft a letter to the Board of Coroners asking them to review the testimony from yesterday and to consider changing the rule, and also draft a letter to the governor's office asking the Department of Health to ask for authority to have money in their budget for 2 medical examiners and possibly a central medical examiner's office. And then as far as the counseling and psychology compacts, you want bill drafts for both of those with effective dates immediately.
Very good. And the reminders to the chairman.
And the reminders to the chairman, I have those as well.
That's probably should be number one, the reminder to the chairman.
No, I have those highlighted, I'll remember.
Anything further you can think of, Chairman Wilson or Representative Conley, anything?
Yeah, Mr. Chairman, I'd like to go back to this morning, and we had kind of long discussions this morning, and the one suggestion that we had was the bill that was looked at by the Judiciary Committee. I'd like to have us kind of look back at that at our next meeting. So that was the juvenile delinquency removal placement recommendations. It was the one suggestion for us to go forward. And so I'd like to know a little bit more. I'm in particular interested with Senator Wasserberger shared at lunch that he was part of the group that came up with the multidisciplinary teams. And it seems to me that this bill here in part kind of just expands or defines a little bit better what they're doing. So I'd like to have us keep that on the agenda.
I think that's reasonable. Thoughts, Chairman? I think that's perfectly reasonable. We won't have a bill draft, but we will have that on the agenda to review.
Mr. Chairman, could we have a bill draft that would have this be a Labor Committee bill that we could just, because that would be our last time to.
Yep, that's true.
Okay.
Committee? Would the committee agree with that? We have a motion to have this as a bill draft. Oh, go ahead, Representative.
Oh,
What?
well, just agree, Pepper. I'm sorry, Mr. Chairman.
The bill draft that Judiciary had, that we had before us, or that was in our materials, and the request is that we actually have a bill draft to review in October and take that forward perhaps as a committee bill, if so desired. So we would have a bill draft created and that we would take that forward as a committee bill at our October meeting. Go ahead. Chairman
So I would agree if that's a motion, but I would also suggest that there was discussion from the presenter that the two components about, what was it, there were the last 2 pages, something, or the
age
15,
changes.
the age changes, that that be deleted. So I would ask Alyssa to delete those 2 sections on the age changes at the end of the bill.
Is the person that made the motion good with that?
Sure.
Good. Do we have a second on that motion, by the way? He thirds that. Okay, we'll imply that to be a second as well. Okay, committee, you've heard the motion. Oh, we got to, go ahead, comment.
Comment on that, as I believe we need to have somebody from Judiciary where they didn't take it up, come in and talk to us, or a letter explaining why they didn't do it and what their beef is on it.
I actually do have a request out to the Judiciary Chairman to find out what their discussion was, and so we'll have more on that before we come to our meeting. So it's a topic that we can discuss. Representative? You do need to be on that speaker.
Okay,
yes.
what I'm wondering is, since we were talking about, Mr. Chairman, with the last thing, the pair, and with the juvenile justice and everything, is there going to be, or do we know, or how could we do it, that there is information concerning the juveniles and the possibility of the cannabis and all of those things going along with that? Because they mentioned cannabis, but is there any background information, do you know, with that?
I believe that with this bill, Representative, that may come up in the discussion, but it's not formally a part of the bill.
I'll talk to
But it certainly will come out in discussion, something that this committee will hear again
Okay,
down
thank
the
you.
road. Committee, you have a motion and a second and a third before you to move this ahead as a bill draft. All in favor, say aye.
Aye.
Opposed, say no.
No.
Let's just do a raise of hands because we're all kind of tired. All in favor, raise your hand. 1, 2, 3, 4, 5. I see 7 hands, including mine, that will pass. So we will be hearing that in October in Cheyenne. Further directives, committees, suggestions, ideas, farewells.
Mr. Chairman?
Yeah, whoever said that, I believe that was Representative Flitner.
Yes, sir. Mr. Chairman, we also wanted to hear from the Wyoming County Commissioners Association too on the pathologist program.
You are absolutely correct. We did talk about that. So noted.
That's
Okay,
on
we
my
got it.
list.
Thank you very much for the reminder. Further comments, committee? I would point out and like it in the record that I kept my promise of being out of here by 4 o'clock. Please be sure and turn in your vouchers so you get paid. Everyone have safe travels home, and we will see you in Cheyenne in October.
Bye, everybody.
Hold on, hold on.